Today's topic really exemplifies what makes Mount Sinai special. The topic and the panel are really topics that are developed, the guidelines are developed here at Sinai, and the people that you're going to see on the panel are those that you would see at a American Heart Association Grand Panel or American College of Cardiology. Today's visiting professor, Dr. Mahaffey, has worked very closely with Dr. Fuster and Dr. Halpern on many seminal trials in atrial fibrillation, and we'll hear more about him from Dr. Fuster. Just to tell you a little bit, we're coming in the last turn for this year's academic year visiting professors. In April, Dr. Sidney Smith from University of North Carolina. In May, Dr. Sam Goldhaber from Brigham and Women's. And in June, Paul Armstrong from University of Alberta. I really don't want to take any more time. We have an excellent panel. Dr. Lin put together an excellent monograph, really a great paper, and Dr. Fuster is going to introduce our visiting professor.
Thank you, Dr. Goldman. I'd also like to give a special thanks to Dr. Halpern, Dr. Fuster, and our guest, Dr. Mahaffey, for this opportunity today. Our topic for the panel will be the new oral anticoagulants for stroke prevention and atrial fibrillation. In particular, we will focus on considerations to make in using these anticoagulants in specific situations. Now, warfarin has been well proven to decrease the risk of thromboembolism associated with atrial fibrillation and has been used in this role for over 2 decades. However, use of warfarin has been complicated by medication and food interactions and frequent dose adjustments. In response to these drawbacks, 4 new anticoagulants have been developed and approved for use in atrial fibrillation since 2010. These drugs, often labeled as the new oral anticoagulants, or NOACs, include the direct thrombin inhibitor dabigatran, as well as the direct factor 10A inhibitors rivaroxaban, apixaban, and most recently edoxaban. The rapid emergence of these new anticoagulation options introduced new challenges for clinicians, particularly in selecting the optimum agent for their individual patients. Several characteristics of the available agents must be considered when selecting an anticoagulant, including pharmacologic properties, efficacy, safety, dosing regimens, and how specific patient characteristics can impact drug action. Now, caution is necessary in attempting to compare one NOAC with the other, as there are no direct comparative studies that have been conducted. However, there are some indirect comparisons that suggest that there's some differences that the NOACs have that may be considered in deciding which anticoagulant to use in the particular patient. The bulk of available clinical information on NOACs comes from 4 pivotal trials, each which compared the medication to warfarin. The key trials include the RELY trial for dabigatran, the ROCKA-AF trial for rivaroxaban, the Aristotle trial for apixaban, and the ENGAGE-AF TIMI-48 trial for edoxaban. All these were large, multi-center, international randomized trials. However, there are many notable differences between the trial designs and study populations. This includes dose reduction strategies, the inclusion of valvular heart disease, the risk profiles, and the time and therapeutic range for the warfarin control group. These differences make it very challenging to compare the performance of the NOACs across all the trials. In the primary outcome of stroke and systemic embolism, all of the NOACs proved non-inferior to warfarin. Only dabigatran 150 milligrams BID and apixaban were statistically superior to warfarin in the primary efficacy outcome. All of the NOACs showed benefit in reducing hemorrhagic stroke. However, when you look at specifically ischemic stroke, only dabigatran 150 milligrams BID showed a significant decrease compared to warfarin. All of the NOACs had a reduction in the secondary outcome of all-cause mortality of approximately 10%, which reached statistical significance in some of them, but not others. In the safety outcome, apixaban and edoxaban showed a reduction in major bleeding compared to warfarin, while dabigatran and rivaroxaban were non-inferior to warfarin. What was consistently found across all the NOACs was significantly lower rates of intracranial bleeding, at least 1/3 reduction compared to warfarin. Now, this situation becomes more complex when trying to use this data to select the anticoagulant for a specific patient. We will discuss many of these scenarios in our panel discussion, but I'd like to give two examples. Consider a 54-year-old woman with atrial fibrillation, hypertension, and a history of a prior stroke. She is otherwise quite healthy, with a creatinine clearance of 100 and no prior bleeding history. Which anticoagulant would you choose in this situation? Well, in this scenario, based on the data, you would not use edoxaban. In patients with creatinine clearance greater than 95, there's a 40% reduction in drug levels. In ENGAGE AF, patients with GFR between 50 and 80 had fewer ischemic strokes with edoxaban. But when you look at the GFR range from 80 to 95, there's no difference. And then when you look at the range from 95 and up, you see actually an increase in strokes with edoxaban compared to warfarin. Rivaroxaban or perhaps apixaban would be reasonable choices, but one could make the argument about using dabigatran for this patient. She's at higher risk for recurrent stroke given her prior ischemic stroke, and based on the primary analyses, dabigatran is the only medication that was shown to be superior to warfarin in reducing ischemic stroke. Let's do one more example. An 85-year-old gentleman with atrial fibrillation, chronic kidney disease, with a creatinine clearance of 35 and a prior GI bleed. In this situation, you would be very hesitant to use dabigatran. In the elderly, there's a trend towards more extracranial bleeding, and dabigatran in all patients has been shown to cause more GI bleeding than warfarin. Additionally, it is the most renally dependent of the NOACs, with 80% renal clearance, and has the greatest potential for accumulation in these patients. In this situation, you have some options, but you could consider using apixaban as the least renal clearance, and subgroup analyses have shown that it maintains its efficacy across the elderly. These are just two examples that are fairly straightforward, but they help to illustrate some of the considerations you can make in selecting an anticoagulant. In general, though, it is important to realize that there are probably more similarities than differences among the NOACs. As a class, the NOACs has been consistently shown to be non-inferior in preventing stroke, while reducing intracerebral hemorrhage and decreasing all-cause mortality compared to warfarin. The differences in the trial results may be more due to variations in the doses, the trial design, and the study populations than intrinsic differences in the drugs themselves. Thank you.
Thanks very much for this short but very complete outline of the new oral anticoagulants in warfarin. Thanks very much, Edward. Now it's a pleasure to introduce today Dr. Kenneth Mahaffey, who is the professor of the Stanford University School of Medicine, Vice Chair of Clinical Research, Department of Medicine, and Director of the Stanford Center for Clinical Research. Dr. Mahaffey actually was born in Seattle. I don't mention the date of birth, although it's stated here. He was educated at Stanford, so he had to go back. So he spent his medical degree years obtained his medical degree at the University of Washington, the School of Medicine. And then he moved to the University of Arizona, where he was intern resident in medicine, and then he was the chief medical resident there. Then he moves to Duke in 1993, where he was a fellow in the Division of Cardiology, and he finally became assistant professor, and eventually he became associate professor of medicine at Duke and professor of medicine with tenure. It was in 2013 when he moved to Stanford as a professor of medicine, as I mentioned, and actually vice chair of the Department of Medicine. So during the time at Duke, he worked with Robert Califf at the Duke Clinical Research Institute, and he talked this morning, a wonderful setting to work with. And eventually, however, he decided to move to Stanford with Dr. Harrington, and he's having a great time there, and he's enjoying, and He's quite excited, positive, optimistic. You should hear him this morning. And if you have some degree of depression, please call him. He will cheer you up. Well, he has a number of assets in his CV, like professional awards that began when he was a student, when he was a medical resident, when he was a fellow, etc. And he got very significant awards. Now, in terms of his professional life, and I have to go quickly because he has to catch a plane today, and we really have to finish by 6. He's in the editorial board of 8 journals in the cardiovascular field. He actually is in the steering committee or principal investigator of 25 trials. He has a record, but even he has more of a record as chairman of the events committee in 75 trials. So you have a question about events, call him. He really he has more experience than anybody. Now, going back to his publications, he published in antithrombotic agents, coronary artery disease, atrial fibrillation, and even in the early years, he was working experimentally in cardiac arrhythmias and otherwise. He actually has more than 300 papers, and he's quite of an accomplished young individual. I congratulate you for everything you have done, Kenneth, to visit us today. The fellows were very excited about what you told them, and thank you very much. So let me give you this plaque for you to remember our presence. Okay, to you for outstanding teaching, wisdom, and expertise as the annual Anandi Sharma visiting professor in the Simon Dag Memorial Lecture. Did you know Simon?
I did not know Simon.
No, yeah. Anyway, he was a real,
Personally.
yeah. Anyway,
Terrific.
congratulations.
Thank you so much.
Good.
Thank you.
Thank you. Okay, so you can sit in the middle.
Okay.
And now I'm going to call Dr. Jonathan Hoffman, who is going to moderate this table. In the panel is going to be Vivek Reddy. Is Vivek here? Unbelievable.
On time, too.
Yeah, he's on time and here. So, no, he's always on time. Well, we have to. Jose Meller and Edward
And you?
and me. Yeah, thank you.
Thank you.
Thanks, Jen.
Great. Well, first, let me again add my welcome and thanks to Dr. Mahaffey for joining, and great appreciation to Ed Lynn for a fantastic review of a very complex and easily misinterpreted area. And let me thank those for joining the panel. Let me begin with a few questions. First, for Dr. Meller. Dr. Meller, for those like Dr. Mahaffey who might not know him, is a masterful clinical cardiologist who cares for a large number of patients with atrial fibrillation. Dr. Meller was relatively early to incorporate the so-called NOACs into practice on a case-by-case basis after the successive approval of these agents by the FDA. And from the earliest one, which was dabigatran, to the most recent to become available, edoxaban, how have you approached the choice of which drug for which patient? What things do you think about in making a selection?
Well, at the beginning was very easy. There was only one. And when patients had a reaction to that one, which was 1/3 of the patient had GI intolerance, and as soon as rivoxaban came around, all of those immediately were started on Xarelto at that point. And when the next one came out, apixaban, patients had some GI. It came out as superior, but then there was a questions, obviously, of what shots are you using. You cannot compare them. Rivoxaban was with the higher shots. Those patients bleed more. Apixaban was with lower shots. Those patients bleed less. You cannot compare them. At that point, it became whichever one the insurance paid, whichever one had a card that would make the drug very cheap. And at this point, I found fantastic the presentation of Edward, that he actually mentioned exactly the way sometimes we approach it. A 50-year-old who has nothing else, had a previous stroke, probably at that point Pradaxa would be the drug that we might consider first. In a patient with GI bleeding or patient with any GI intolerance, Pradaxa is completely out immediately. And then we have the discussions of the others. The question of the renal function becomes a question now. And we were just talking with Dr. McLaughlin that, interestingly enough, in most of the laboratories, we don't know what exactly the GFR is. It's usually reported as normal, over 60. We don't know if it's 97 or if it's really 75 or whatever. So it becomes a little tougher with the newest one, with the Doxaban. So I use all of, let's say, the previous three. With the new one, I'm still waiting a little bit, but I'm saying I use them all. The decision is, the dose might push me more in one direction than anything. Let's say in an older patient, interestingly enough, where Pradaxa may be okay, but you cannot use with a GFR of 35, let's say, Pradaxa 75, which you would prefer to use. I think the Pixaban were quite smarter on really adapting to GFR, age, and what is the third one?
Weight.
And weight below 60 or below kilos. So all of those, but I use all of them. I think they're all superior to warfarin.
Thank you. Thank you. Let me ask Dr. Fouch. We've all been intrigued by the results of the recently reported Legacy trial that showed a reduction in the rate of developing recurrent atrial fibrillation associated with interventions to control obesity and excess body weight in patients who've had previous episodes of atrial fibrillation. There's also evidence that patients who are overweight can lower their risk of stroke by losing weight. The doses of these NOACs are generally not adjusted based on patients' body weight, except, as Dr. Meller pointed out, for dose reductions for apixaban and edoxaban in patients with low body weights who are older or when there's impaired renal function. Now, when you choose an anticoagulant for a patient with atrial fibrillation, even though we don't have an increment in dose for the more obese patient, how does obesity affect the way you would select a specific agent? Do you weigh that in your decision?
Well, first of all, I look at the age of the patient. That's number one. In terms of obesity or no obesity, I have to say to you, I may still use a lot of warfarin because I want to make a point that maybe is important. In all the trials, the therapeutic time for use of warfarin was 60 to 65%. In the patients that use warfarin, it's close to 100%. And I don't know what the trials would have shown if a patient has been on warfarin and is very consistent, why I have to change with another drug. So the weight is irrelevant because I use the INR. So then if I start the drug de novo, I may use, my preference is to use a drug with a single dose to start with, and to use apixaban if the patient has renal dysfunction. I do not look at the weight, at least at this time, but certainly I feel very obsessed to the fact that weight reduction is critical if you're dealing with this disease, and I think it's more important that the use of the drug according to the weight of the patient.
Thank you. You mentioned this idea of the time in therapeutic range and the performance of warfarin. Dr. Mahaffey, you have seen these analyses with virtually all of the novel agents. Maybe you could share some insights about the way they compare in relation to how well managed is the warfarin in the trials.
Yeah, certainly. But obviously, first, I just want to thank Dr. Fouch and all of you here at Mount Sinai for what a great opportunity to come and visit and spend a day here. I had a fantastic time with the fellows, and I'm very humble and appreciative. Thank you. This issue of the time in therapeutic range has had a lot of controversy. Probably, Jonathan, you and I have struggled with this the most because in the Rocket AF trial, we had the lowest time in therapeutic range, and great criticism for the conduct of the trial. But I know you will I will remind people that the challenge with warfarin is that when you look at clinical practice settings outside of clinical trials, for patients on warfarin, the time in therapeutic range is only about 50%. So the trials actually did better than routine clinical practice. Still not great, but better. What we have seen across the three original trials, Rely, Aristotle, and Rocket AF, and I haven't seen this yet from the engaged investigators, perhaps you have, is when you look at the time and therapeutic range in terms of quartiles using a metric of the center TTR, and you look at the treatment effect of the novel anticoagulant, it was consistent across all tertiles of therapeutic range without any statistically significant interaction for any heterogeneity in the treatment effect of the novel anticoagulant versus warfarin in relationship to the time and therapeutic range. What does that all mean? It means that even in patients who had very poor INR versus patients who had very good INR, the benefit and effect of the novel agent was the same. So, important issue to think about, but it doesn't really drive my decision about whether or not to use these agents and which one in particular.
I think it's a great point. I think the way that we manage warfarin has a lot to do with the way we manage everything else about the patient, so that event rates get better in both arms of these trials, whether the NOAC arm or the warfarin arm, the better the time and therapeutic range. So, yes.
Actually, can I just follow up with a question to Ken or to you also, John? Has anybody looked at, in any of these trials, instead of looking at from the perspective of quartile of the center INR, a TTR, center TTR, but if you just stratify by patient, you know what I mean? Take the patients who are the first quarter and the last quarter and the quarters in between of TTR.
Ken, you want to take your stab at that?
Yeah, sure, and maybe you can weigh in as well because you've been involved in a lot of these discussions and analyses. So we've done two things in Rocket AF, and I know that others are trying to replicate this in the Aristotle database, is we actually did look at center TTR as a continuous variable and plotted that in terms of the hazard ratio of the treatment effect. And what happens is you get a very consistent hazard ratio compared with the overall trial until you get center TTRs that are astronomically high, like 85 to 90%, which we know, unless you're in the country of Sweden, or maybe here at Mount Sinai,
Hardly here at Mount Sinai.
That goal. And then the other thing we've done is we've gone back and looked at the individual predictors of patient TTR. And that's still a real challenge, isn't it?
It is.
And there's a lot of very important clinical and medical history features that go into predicting time in therapeutic range. Like younger patients actually do worse than older patients. Patients with heart failure do worse. But there are very important things that I don't think we measure well, and that is socioeconomic factors and healthcare system care delivery patterns that really affect time and therapeutic range that we haven't completely unraveled.
I think another concern, and the reason it hasn't widely been done on the per patient basis, is that we can look at an INR and a TTR on an individual patient, but we can't make a direct comparison to how things are in the novel agent arm on a per patient basis because there's sort of nothing to really measure. And although the time and therapeutic range is reported in all these trials, it's not calculated the same way in all the trials. Some trials have blanking periods. They don't count the INR during the first week or two after you stop or start an anticoagulant. Others, like in Rocket, include all INR values from the very first dose of the anticoagulant. So they're not strictly comparable. And I think it's important to realize that some of these differences are methodologic, not just in terms of treatment performance.
Just a comment, all the studies done before what you mentioned, there is a line which is absolutely exponential with the TTR and the event.
Yeah. The events go lower, the better is the time and range. The problem is everything else gets better too. Statins, ACE inhibitors, blood pressure control, everything else improves with the better anticoagulation. Let me ask Dr. Mahaffey, I'm going to front load the questions for you because of your planned departure. So the most consistent finding across all of these phase 3 studies of the novel agents, and perhaps their most convincing advantage compared to even well-managed warfarin, is this marked reduction in the risk of intracerebral hemorrhage, which is, of course, the worst complication of anticoagulation, both in terms of mortality and lasting disability. Can you give us any insights as to the mechanism by which these drugs are are better than warfarin? Why are these intracerebral hemorrhage rates so remarkably low, 0.11%, even with dabigatran, which accumulates a good deal?
Yeah, this was really the biggest surprise. I don't think anybody who's going to be honest would have said now that this is what we predicted going into these programs. We all thought it would be reduction in ischemic strokes. And when we first saw it in Rocket, and they saw it with dabigatran, and now with rivaroxaban, we struggled to come up with some hypotheses about why this observation was seen. And I've never had a good explanation, even from world-renowned vascular biologists. Everybody had a different idea, and whether or not this is the mechanism of warfarin and tissue factor levels in the brain compared to other parts of the body, or are these actually intracranial hemorrhages that start off as ischemic strokes but then convert, is really unknown.
Okay.
But the fact now that we've seen it across 4 large programs, it's real.
Yeah.
How to explain it, we're still struggling with.
I got it. Well, in reference to this, Dr. Reddy, 2 weeks ago, the FDA approved the Watchman left atrial appendage occlusion device for patients with non-valvular atrial fibrillation who are at increased risk of stroke or systemic embolism based on their CHADS-2 or their CHADS-2 VASC scores, and they're considered eligible for anticoagulation with warfarin, but who have some appropriate rationale to seek a non-pharmacological alternative, taking into account the safety and effectiveness of this device and presumably the experience of the operator compared to warfarin. I would like your comment about this in the context of how one makes clinical decisions in an era when there are also novel agents.
No, I mean, that is the question, right? I think the trials, the 2 trials, the randomized trials that were done for appendage closure, I think that there's good data that shows that they're as good, if not better, than warfarin. So I mean, we can debate that, but I think that data is pretty good. Obviously, the NOACs have since been introduced, and just as they haven't been compared to each other, of course, the appendage closure devices have not been compared to the NOACs. But you know, the fact is, even when you're thinking about warfarin, I think when you think about the inclusion-exclusion criteria of the trial, and then as we've talked about, when you think about who the patients were actually enrolled in the trial, I think that physicians made decisions about putting patients in the trial because there was some reason why they were not great candidates for warfarin. Indeed, that's why, as you just read the indication for use statement, that's why the FDA worded it that they have a rationale for an alternative to anticoagulants. So I think the fact remains most patients can and I believe should be treated with either warfarin or the NOACs as primary therapy for stroke prevention. But having said that, there are a lot of patients who don't fit that category, either because they don't tolerate the NOACs or they won't tolerate the NOACs for any one of a number of lifestyle reasons. Or as you know, the estimates are still right around 40% of patients who should be on an anticoagulant with atrial fibrillation are currently not receiving an anticoagulant. And those numbers have changed really minimally, at least the last data that I've seen, with the advent of the NOACs. So there's still a lot of patients who are at need who are not being treated. And then there's some special categories too. They're the extreme, I won't say extreme elderly, but the elderly who, for whom the drug-drug interactions, risk for falls, et cetera, who also fit this category. There are patients who have renal dysfunction who may not be good candidates for certain anticoagulants. And then the other really tricky one are the patients who are not good with compliance with the anticoagulants. And you know, I think we probably see this less here in our practice. But you know, I was giving a talk with the folks at Montefiore, and we were talking, and it was interesting to me that they saw this as a big need for their patients because of lack of compliance, whether it's Coumadin or the NOACs. So that's a much more difficult population to study. For ethical reasons, it's hard to enroll those patients in a clinical trial, and yet it's a big population in need.
Great point. Did you want to add a point?
Yeah, I mean, this issue of compliance is really challenging us because obviously with warfarin, you just get an INR, you know if they've taken it or have appropriately or have some on board. And one of the things that we talked a lot about at the ACC meetings and some symposiums were, what do you do when a patient who is supposed to be on a NOAC and you're coming in and you're going to cardiovert them after 3 weeks of therapy? How obligated are we as clinicians to confirm that they were being compliant? Is it just asking them, where we know that a lot of people won't necessarily tell the truth? If they've missed one dose?
I think it's a
don't
huge
know what
problem.
the right
My,
answer
my
is.
first experience with cardioversion on a NOAC was a woman that I gave dabigatran when it was the only one available after the publication of Mike Zekowitz's paper, which was really at that point the largest experience in cardioversion. And I met her on the day of the cardioversion after her 3.5 weeks of dabigatran, I thought, and said, now, have you been taking those pills every day, twice a day? Yes, I have, doctor. And she whipped out the bottle of metoprolol. So be careful, okay? Just be careful.
I have a
yes.
question, because there are some papers coming out now. The APTT on the dabigatran and the PT on the 10A inhibitors appear to give you a sense if they're taking it or not. Is that correct?
They do, but they have an awful lot to do with when you do the blood test in comparison with when the drug was taken. And of course, that tells you, it's a little bit, I always think of it like flossing when you go to the dentist, you know? Yeah, you did it that morning, but what did you do last week? And then prior to cardioversion, that's a concern, okay? So I think it's an issue that we don't have a good way to assess. As you say, not only is warfarin measurable over a period of time, but it's forgiving if you skip a dose. These new drugs are not necessarily forgiving. You're not anticoagulated tomorrow if you didn't take the dose today. So just a concern. I'm going to ask Dr. Fouster a question, and then I'm going to pass it on and ask the same question to Drs. Meller and Dr. Mahaffey. And don't you worry, Dr. Lin, I'm coming to you soon, okay? So aside from the patient who's had, say, a drug-eluting coronary stent during the past 6 to 12 months, not that kind of case, because we know there are uncertainties there, but how do you approach long-term antithrombotic therapy in a patient who has atrial fibrillation and, say, a CHADS VASC score of 3 or 4, who's more than a year out following an MI? What do you do with the platelet inhibitor? Do you use it with a NOAC, with warfarin? What is your approach? And does the presence of concurrent coronary disease influence your choice of which anticoagulant to prescribe?
Well, it's nice you asked me after 1 year and not before.
Yeah.
But after 1 year, obviously, you give anticoagulants. I think the question is, you give an anticoagulant for the atrial fibrillation, then we can discuss which one. And then you give a platelet inhibitor, and this can be actually the aspirin. But I want to make a comment here. Is at least oral anticoagulants, warfarin, is as effective as aspirin in coronary disease. So if for whatever reason you are worried about bleeding, I would give an anticoagulant alone on a patient who is actually long-term, after myocardial infarction. However, the ideal would be, today the data is only the use of warfarin and aspirin, which is justified. I would never use 3 drugs because the bleeding is very high. And then we can discuss what about the new oral agents together with aspirin. Well, there are 3 trials going on, which we don't have any idea what they are going to show, but we still don't know how these drugs are going to do compared with together with aspirin or even clopidogrel.
Does it make you gravitate toward warfarin in a patient with chronic coronary disease? Or are you open to using the novel agents?
Well, I think frankly, I faced this patient already, and I have to tell you, I use a new oral anticoagulant. I don't have the data yet, but with a very low dose of aspirin of 81 milligrams. But I think the data is not out, though.
Exactly. Dr. Meller, you have an approach to this patient, chronic coronary disease, not an acute syndrome, not a recent stent. As Dr. Fouster mentioned, there are trials ongoing to look at the recent stent. And now the patient also has atrial fibrillation with a reasonably high risk score.
So in all these trials, there were patients who took the NOAs with 1 antiplatelet, and they bled more with that antiplatelet, or with warfarin, they bled more. So you bleed more with them, but after 1 year, if the patient had a stent, simple stent, I might leave the patient on a NOA and an aspirin. If the patient had multiple stents or complicated ones, I would leave them on NOAA and Plavix. But if the patient, I want to keep them on warfarin, it would be equal to me with that antiplatelet that I decided. But it would be one antiplatelet according to what condition the patient has.
Dr. Mahaffey, some insight? You also work in the antiplatelet world.
Yeah, I mean, I think Dr. Fuster's comments that, warfarin is really pretty good drug for secondary prevention in patients with cardiovascular disease and prior MI. And we've got an incredible body of literature from the 80s and early 90s. But yet, despite that body of literature, we never really used warfarin in the US. It was much more common in European countries and some other parts of the world. So I think we can't forget those learnings and observations and studies. If you look back at these trials, anywhere from 15 to 25% of patients in these large NOAC trials were on chronic antiplatelet therapy, almost all aspirin, very little P2Y12 inhibition, and almost none. In fact, most of the trials prohibited triple therapy for any extended period of time. So we don't have any insights on triple therapy. I do feel comfortable that using a NOAC with a very low dose of aspirin, even though we still don't know the right dose of aspirin, as we talked about at lunchtime today, I feel comfortable with either a NOAC with very low dose of aspirin, particularly if their bleeding risk is low and their CHAD score is high.
How about, you've worked not only in the NOAC development, but also on evolving approaches to platelet inhibition for patients with coronary disease, particularly the acute coronary syndromes. And several of these newer agents have been associated with adverse neurological outcomes, especially in older patients with prior stroke or transient ischemic attack. And much of this problem seems to be related to cerebral bleeding. Are there any lessons that we can take from the NOAC experience that might guide clinicians in selecting amongst the various antithrombotic options for patients with acute syndromes, in terms of selecting an antiplatelet or some combination of agents?
Yeah, the challenge here is, as you're alluding to, is that intracranial hemorrhage is a really feared complication. We all got involved in this with the thrombolytic therapy era, when morbidity and mortality was 2/3. Half the patients died, and another third of them had significant morbidity. Not quite as bad in the acute coronary syndrome era, but I had the recent opportunity to look back at 4 of the large ACS platforms and looked at all the intracranial hemorrhages, and we had about 150 intracranial hemorrhages. And the key predictors are what you would expect: older age, prior stroke or TIA, elevated systolic blood pressure, and then number of antithrombotic therapies on board. And I'm using antithrombotic therapy carefully because it's both anticoagulant and antiplatelet. And so I am, particularly in patients with prior stroke or TIA, I am very hesitant to use triple therapy or very potent dual antiplatelet and anticoagulant therapy because of the experience we've had from the prior programs.
Okay, that's very helpful. And I think, although we've identified some circumstances under which it's appropriate to use an anticoagulant with low-dose aspirin, it's also important to look for opportunities to reduce the risk of intracranial and intracerebral hemorrhage. And one of them is to avoid the unnecessary use of combined therapy. So if someone doesn't really need to be on that aspirin with their anticoagulant, probably that and controlling blood pressure are about the only things the doctor can do to reduce the risk of brain hemorrhage. Dr. Lin, time for you. As a young cardiologist who's now reviewed the literature with a bright eye and a bushy tail, what parts of the data are you inclined to consider when you're selecting the most appropriate anticoagulant for your patient with atrial fibrillation? What elements of the data strike you as the most pertinent?
Okay. Well, I do want to reiterate, and I think we've talked about this at length, is that the NOACs are fairly similar in overall kind of what they do. So you're kind of nitpicking when you get to the fine details. They all certainly, they are all non-inferior in stroke. Mostly decreasing hemorrhagic stroke is the key. And intracranial bleeding is kind of a big thing. And all of them, in general, do reduce probably all-cause mortality to a certain degree, around 10%. Now, when you look at the details, I think certainly the renal dysfunction part is kind of almost low-hanging fruit for some of it, because there's definitely a wide range of effect on the renal dysfunction. They have different elimination percentages. Dabigatran the most at 80%, while apixaban probably the least at like around 25% renally eliminated. And then you have edoxaban, which clearly when you get into high GFRs, that certainly is less effective and may cause even more ischemic stroke than warfarin. And so that is kind of a category you have to keep in mind. But certainly when looking at wide range of GFR, I thought the interesting part was that the FDA actually, the indications went down to a GFR of 15 milliliters a minute for a lot of the drugs, while all the studies we looked at was 25, 30 was the cutoff. And so there's a lot of patients when you get down to the low ranges that haven't quite been studied, but when we look at them, well, when we prescribe drugs, we have to keep in mind with that. But certainly with dabigatran, when you get down to the 30 to 50 range, you start getting concerns about whether there's signals for increased bleeding in that group.
So what's the deal here? Dr. Mahaffey, what's with the FDA dosing recommendations and the labels for the novel agents that seem to deviate from the evidence in the pivotal phase 3 trials, where particularly as regards patients with impaired renal function? Do you use these patients in these drugs in patients where creatinine clearance is, say, below 25 to 30? We have a 75 milligram twice daily dose of dabigatran. We have a label for apixaban that even includes patients on dialysis that haven't been studied. What's the story there?
I have no frickin' idea.
An honest man.
I don't know what they were thinking. I think it's really problematic to be giving drugs to large numbers of patients based on modeling of PK/PD parameters. I think it's ludicrous.
Yeah, it's really
and you know, we especially as Dr. Fouster's already said, we've got drugs, and we could even debate, but we've got drugs like warfarin that are pretty good in that moderate moderate to severe, in that 15 to 30. Now, you can argue with some of the recent data that's come out from Winkelmeyer and others that warfarin, we got to be a little more cautious than I think we are in the real severe renal impairment.
That's right.
But to be giving drugs that have never been studied in those patient populations of 15 to 30 or 15 to 25, I don't use it, and I wouldn't recommend it.
We don't have the...
Just a comment about the FDA.
Yes.
You know, I have been dealing with the FDA on the poly pill, and one thing I learned is exactly what you said, is all modeling. They use with PK, PD, and they make their decision, which is completely irrelevant when you look at the trials. In other words, there are guys that do nothing else than modeling there. In fact, we face with the poly pill a modeling situation constantly. So I am not surprised that they come with a dose that has not been tested.
Yeah. So let me move to the politically incorrect question then. Our friend and colleague Robert Califf has recently taken a position at the FDA right around the same time that Margaret Hamburg is stepping down from her position as commissioner. Now, whether or not Robert becomes the new commissioner, do you think there are going to be changes in the way the agency approaches labeling in relation to trial evidence? Do you have any sense of that? This is for Dr. Mahaffey, the only one who we can safely say, because you can answer it and get out of town.
Well, do I have to acknowledge the conflict? Obviously, I give a large part of my success in my career to the good Dr. Califf. And I'm actually delighted he took the job. I think that his rational and careful thought will provide a really important foundation for the agency. The challenge that I think he'll face is, will Washington, D.C. let Rob be Rob? And if he can be Rob Califf, I think he could make some big advances in our ability to develop drugs in a rational and thoughtful way, and therefore get them into the public domain. If D.C. won't let Rob be Rob, we may still be mired in the quagmire that we're in now.
Okay, well...
Was that politically correct?
That was perfect, and you didn't say one negative thing about Congress. That was amazing.
And I'm not running for office.
Let me ask Dr. Miller. You know, we've been cautioning about the use of these novel agents in patients with severely impaired renal function. What's your experience with warfarin in patients with atrial fibrillation who have advanced kidney failure or even on dialysis?
They just bleed more.
They bleed more.
The truth is you have to practically do an INR almost weekly, and even with that, the patients will bleed more. But you are stuck because they need anticoagulation, and it's a big problem.
Right. And a little dirty little secret was shown at the ESC Congress last year, and I think we'll expect to see a paper published soon from the RELY investigators that renal function declined more over the long term in patients in the RELY trial of dabigatran in the group that was given warfarin than the group that was given dabigatran. So that obviously needs to be confirmed in another data set, but wouldn't it be a kick in the head if warfarin turns out to be bad for the kidneys? Again, more information is needed. What about antidotes? Let me ask you about the antidotes. What's your view, Dr. Mahaffey, of the development process, and when and how often will we use these things, and are there potential pitfalls that might be related to rebound, thrombogenicity, or other concerns?
Well, yeah, I mean, I think everybody's well aware that there's 3 compounds fairly far along in the clinical development process, one specifically for dabigatran, another one that's specific for the factor Xa inhibitors, and then a third one that we don't really understand how it works, the PER-777 compound. You know, the FDA is looking at this very closely and has given it a rapid, I'm totally blanking on the name of the pathway forward, but they've given it a fast track forward for development. It's likely that we'll have some antidotes available at the end of this year or early next year. But I'm not sure what they're going to really mean for clinical practice. I always remind the fellows and the house staff that the clinical trials were done without an antidote. And as Edward nicely pointed out, we have at least similar, if not better, bleeding in general, maybe a little bit more GI bleeding, and marked reductions in intracranial hemorrhage. And I don't know how an antidote's going to help once you bleed in your brain. Tragic, but that's reality. I do think that it may help physicians that are anxious about these agents, maybe not as familiar with the data as many of us are, to go ahead and prescribe it. Now, quick story, and I'm not violating any HIPAA rules. My father has atrial fibrillation, and I said, Dad, he was on warfarin. I said, Dad, next time you go into the anticoagulation clinic, and this was around about 2011, 2012, I said, ask the docs about these new drugs that are out there. You should think about going on one, but I want your doctors to talk to you about it. He said, calls me back, son, I took your advice. I talked to my doctor. They said there's no antidote, and that if I bled, I might die. I better not go on them. And that's the angst out there in clinical practice in a real-life situation. So I think maybe we might get more prescribing because of the safety net of knowing there's an antidote. I don't know how much they'll actually be used.
Dr. Fouster, comment on this issue of the antidotes?
Well, first of all, these drugs are all short-acting. So this is not vitamin K inhibition. So you know that by 12 hours, maximum 24 hours, you don't have the drug. So you can take 2 approaches. One is to be cool and not to do anything. And the other is to give concentrates, you know, or factor 7A activator. I mean, there are ways to approach this quickly on both the vitamin K inhibitors and the oral. What you cannot do is to reverse anything with plasma blood, or, you know, so but you have to do either concentrates or
Fibrin donors of some kind, yes. Yeah. You know, it's interesting to me, there are 7,000-something emergency departments in the United States, and since, you know, in a hospital setting, any supply, one is none, you have to have 2. Now there are going to be 14,000 vials of the antidotes for every one of these compounds sitting in emergency departments, and I think they'll be thrown out at the end of the year, and another 14,000 will come forward. So we'll see how many of them actually get used. Dr. Reddy, you and your colleagues often perform pulmonary vein isolation and related ablation procedures for patients who have symptomatic atrial fibrillation. How do you approach anticoagulation before, during, and after ablation with reference to warfarin and the novel agents?
So before and during is actually the easy part of the question. So in general, we like these patients on some sort of anticoagulant before the procedure, leading up to the procedures, because whether or not they've had a stroke, they may have some small clot in the atrium, and you don't want to dislodge it during the procedure. So then the question is, how do you manage the peri-procedural aspect? Over the past, since we've had warfarin for many, many decades, what's evolved basically since the mid-2000s is the concept of doing uninterrupted anticoagulation with warfarin. So we do all of our ablations, since basically about 2003 or 2004, every one of our procedures has been uninterrupted warfarin. That concept is extended, by the way, to devices, pacemakers and defibrillators, for those patients that need to be on anticoagulation. Now, when the NOACs came out, we got very excited with dabigatran because we thought much easier to deal with, et cetera. And what was interesting, though, with dabigatran, we were concerned because of the bleeding issue. So we had a strategy of holding one dose of dabigatran, and we did this there was a paper that was published, our experience along with 4 or 5 other centers, and out of about 300 patients or so, there were 2 patients that had strokes. Now, none of this is statistically significant, but that's with a history of many, many years of never having had a stroke. So we knew that at least with dabigatran, we're concerned about doing uninterrupted, but holding one dose probably was not a good idea. When Xarelto came out, because of that paper that you're aware of, looking at human volunteers using factor concentrate,
Four-factor, they use
Right,
the 3 and 4-factor PCC.
Yeah, the PCC, that's right. So the concentrate, then we felt comfortable, okay, at least we have a strategy. And even though we've never used it, we basically switched to doing uninterrupted Xarelto. In those patients that are on apixaban, we do uninterrupted apixaban. In those patients that are on Pradaxa, I actually tend to switch them to usually Xarelto because it's once a day before I do the ablation. Then afterwards, if they want, we can switch them back. But in the peri-procedural, that's the easiest thing. So I think I've used up all my time.
Bleeding complications?
We have not, surprisingly, we've really not had any bleeding complications, at least anything more than what we'd expect without anticoagulation. I think that, I remember there was one patient who had a tamponade on Xarelto, and we treated like we normally treat. We reversed the heparin, and it was fine. So I'm not saying that there can't be a problem, but at least the event rate is so low that we think this is a very safe approach. The tricky question is what you do after ablation, and that's a much more complicated question in terms of the success of ablation and whether or not you should actually stop anticoagulation, because the conservative position and the position that the ACC/HA guidelines have taken is that you should treat patients after ablation as if they've never had an ablation. You should treat them based on the underlying CHAD score, which is reasonable. But at the same time, we have lots of non-randomized, but still data from lots and lots of patients showing patients with intermediate CHAD score. So let's say a CHAD score of 1 or 2, or maybe a few 3, but mainly 1 or 2, who've undergone ablation, who then have a very low stroke rate. So then the question becomes, based on the guidelines, which are conservative, does it make sense to expose all these patients to high doses, let me rephrase that, expose these patients to anticoagulants and hence the bleeding risk for potentially many years? So that's really, it's not as simple as saying, well, we don't know if you had success, you should just continue anticoagulation. So that's something that needs a randomized study, and there is some randomized data that will be coming out sometime.
Terrific. Let me ask Dr. Miller first, and then any others.
I'd like to interrupt. I hate for Dr. Mahaffey to miss his flight right now.
Okay. We should excuse then Dr. Mahaffey with our great thanks for joining us today. And we have a car waiting for him, so we'll take care of that. But thank you very much. Let me ask the approach to the NOACs in patients with atrial fibrillation who've undergone mitral valve repair without replacement. Okay. Dr. Miller, and thank you, Ken, for coming. Thank you very much. Fantastic. No. Let me ask Dr. Miller. We have lots of patients here. Thank you. Lots of patients undergoing mitral valve repair, and of course, we have very little in the way of experience. We know that we're not supposed to use these agents in patients where the valve has been replaced, although not a lot of information one way or another outside of mechanical valves where dabigatran performed very badly compared to warfarin. Are you willing to give these agents to patients who have valve repair?
Yeah, yes, so far I have done it without any problems so far. I have not done it with artificial valves either.
Even bioprostheses?
Bioprosthetic or mechanical, no.
Okay. Okay. Dr. Fouch, do you have a view about this approach in valve repair? Is it close enough to a native valve that you say, or that it's an untouched valve, that you feel comfortable to use these agents, or do you feel best to keep away until we have better data?
In fact, if you look at the data with atrial fibrillation, about 55% of the patients have mitral regurgitation. So you go the other way around.
Yeah.
Why not?
Well, in mitral regurgitation, there actually has a lower risk of stroke than in patients without mitral regurgitation. If you go back to the early placebo-controlled trials, as long as it's not rheumatic disease, and people theorize about, whether there's washing of the atrium and avoidance of stasis and so on. But the question is whether the endocardial abnormalities that the surgeon causes are in some way thrombogenic in such a fashion as to preclude the use of these agents or not. Obviously, we don't have answers, but you don't feel worried.
No, I don't. Actually, I have used the novel anticoagulants for that purpose, like non-valvular atrial fibrillation.
And Dr. Lin, let me ask a closing question because I realize our time is drawing close. You have now done a comprehensive review of this literature. What do you see as the unmet clinical or scientific questions in this field? What additional data would you like to see, either from additional analyses of the existing trial databases or from new studies to help guide us? Where are the uncertainties?
So certainly there's a lot of areas. If you look at the exclusion criteria for all the studies, you have, like going back to, for example, the renal dysfunction, you have apixaban is actually approved apparently for people who actually have on hemodialysis. At the same time, there's no data on that or severe renal dysfunction. So that's a big exclusion criteria we haven't looked at. The valvular heart disease that we were just mentioning, edoxaban actually allowed for bioprosthetic valves. We don't have the data on that, and probably was a small population at best. And so there might not be enough data for them to process and make a conclusion, but there is kind of potential information about how these NOACs will interact with bioprostheses. Other exclusion criteria, there's quite a few, I think, in there, but I think those are off the top of my head.
An interesting area. There now are several reports of patients with native valve disease in the trials being reported out and not showing big differences in terms of the overall performance of these compounds in people with mitral regurgitation, aortic stenosis, aortic regurgitation. Obviously, hemodynamically significant mitral stenosis was an exclusion. But it's interesting, the stroke rates are running higher in general in the aortic stenosis patients than in the mitral valve disease patients. And I would have thought that bleeding risks would be higher because of the effects on coagulation as well as the vascular lesions in the gut, but we're not seeing that, at least in the evidence coming out so far, so more work has to be done. So let me just leave now for Dr. Fouch to make any final comments about this general field of NOACs, advice for clinicians about how to select them for patients. Do you have advice about what we should do before we close the session today?
Well, I think you discussed what is being done today. I mean, in terms of the future, frankly, I think I would like to see trials comparing one drug with the other. I know it's going to be very difficult by industry to get into this unless it's forced by the FDA. But my main concern in atrial fibrillation is actually, at this moment, aside of the adherence to antithrombotics, which I think is more important than any kind with the use, I'm very concerned about the atrial fibrillation is the tip of an iceberg, and unless we treat the causes, I think we are really off track. And the recent data on obesity, I think, is quite exciting and striking. Absolutely. You can decrease by 50% the incidence rate of atrial fibrillation by losing weight of more than 10%. And I think the fact of the matter is I think we are not paying enough attention to the aspects that are aside the antithrombotics, in which I think the main issue is still adherence rather than which one do you use or don't you use.
Terrific. Thank you very much, and thanks to everyone on the panel and for those of you for joining us today.